Okay, let's jump right in. Today, we're doing a deep dive on the rabies virus, specifically tailored for you, the medical microbiologist working in the Netherlands. Just so you know, all the info we're covering was pulled together using a Gemini deep search, and if you want to check out the primary sources yourself, they're all in the linked Notebook LM document.
So let's not beat around the bush. The virus we're talking about today causes an encephalomyelitis that has the highest case fatality rate of any infectious disease, period. Once symptoms appear, it is almost invariably fatal.
All right, here's how we're going to break this down. We'll start with the specific situation here in the Netherlands, then get into the nitty-gritty of the virus itself, talk about the race to treat and exposure, compare guidelines, and then really focus on your crucial role in the lab. So, first things first, let's ground this whole discussion in the real-world epidemiological landscape that you're working in every single day. You know, when you think of rabies on a global scale, you probably picture dogs, maybe foxes. But here in the Netherlands, the story is completely different. Thanks to some really successful public health campaigns, classical rabies virus has been wiped out in our terrestrial mammals. So that begs a really important question, right? If it's not the classic rabies from land animals, what are we actually worried about here? What should be on our radar?
Well, the answer is flowing right over our heads. We're talking about European bat lyssaviruses, specifically EBLV1 and EBLV2. Now, the really critical takeaway for both clinicians and for you in the lab is that they are both phylogroup I viruses. And why does that matter so much? It means our current vaccines, which are based on the classical virus, they still work. They give us solid cross protection, and that is a huge relief.
All right, we've identified our main suspects. Now let's put the virus itself under the microscope and really understand its structure and its devastating method of attack.
When you see this thing, it has this classic, almost iconic bullet shape. It's a perfect little engine of infection. Those spikes you see sticking out, the glycoprotein spikes, they're the keys that unlock the host cell. They're also the main target for our vaccines. Then you have the matrix protein holding it all together, protecting the precious cargo inside, that helical RNP core. That's the brains of the operation, the replication engine.
And here's a classic finding, something straight out of the pathology textbooks. In postmortem tissue, you might see these things called Negri bodies. You can think of them as tiny little viral factories popping up right inside the neuron cytoplasm. If you see these, it's game over. It's a definitive pathognomonic sign of a rabies infection. Okay, the way this virus moves through the body is, well, it's both terrifying and brutally efficient. It doesn't mess around. It gets in through a bite, replicates a bit right there in the muscle, and then this is the scary part, it hijacks the peripheral nerves. It literally hitches a ride on our own neural highways, taking the express train straight to the central nervous system. Once it's in the brain, it replicates like crazy, and then spreads back out, most importantly to the salivary glands, getting ready to jump to its next victim. So, knowing how it travels, you can see why everything we do is a frantic race against the clock. A race against that axonal transport, because once clinical symptoms show up, it's too late. The game is lost, and care is just palliative. And that's why post-exposure prophylaxis, or PEP, isn't just important, it's everything. And that race starts with something so incredibly simple, but don't you dare underestimate it. We're talking about washing the wound for a full 15 minutes with soap and water. This isn't just about general hygiene. The soap literally helps tear apart the virus's protective envelope, and the flushing action physically removes a ton of the virus. You are buying precious, life-saving time. Okay, now this is where things get really interesting for you as a practitioner in the Netherlands. Let's look at how the global guidelines from places like the WHO and CDC get adapted for local use, right here by the RIVM. So look at the key differences. In the Netherlands, the RIVM gives clinicians a choice. You can use the standard 4-dose Essen schedule or the 3-visit Zagreb schedule, which can be a whole lot easier for patients to actually stick with. The WHO, thinking globally about vaccine supply, is a big fan of intradermal regimen because they use less vaccine per person. Now, what about kids? The principle is exactly the same. The vaccine dose doesn't change, but the rabies immunoglobulin, or RIG, that is super strictly calculated by weight. You cannot mess that dose up. And that, of course, brings us straight to your world, the lab. Because when you've got a patient with neurological symptoms, all eyes are on you to confirm this incredibly high-stakes diagnosis. But here's the challenge, right? How do you confirm this in a patient who is still alive? You can't just take a brain biopsy. The classic Negri bodies are off the table, so you have to get a bit more creative. And this is where modern molecular diagnostics completely change the game. For a postmortem case, sure, the direct fluorescent antibody test on brain tissue is still the gold standard. But for a living patient, RT-PCR is our hero, and the most reliable sample is a nuchal skin biopsy. For virus isolation, you can use cell culture, but here's a funny quirk. You're not actually looking for the cells to die off. Instead, you're using immunofluorescence to see if the virus is there. And antiviral resistance? Well, it's not really a thing in the way we usually think about it. The battle isn't against a drug-resistant virus. It's a race to stop the virus from ever reaching the brain. So, what's the magic number that tells you a vaccine has worked? It's this: 0.5. A neutralizing antibody titer of 0.5 international units per milliliter or higher. When you run a serology test like the RFFIT and you get that result, that's the threshold. That tells you, okay, this person's immune system is primed and ready. They are protected. Okay, so we've talked a lot about what to do after an exposure. Let's zoom out and finish up by looking at how we prevent those exposures from ever becoming a crisis in the first place. This is where pre-exposure prophylaxis, or PrEP, comes in. This is for your high-risk folks, vets, people who handle bats, certain travelers. Now, PrEP doesn't make you invincible. That's not the goal. The goal is to prime the immune system, and the benefit is massive. If someone with PrEP gets exposed, the treatment becomes radically simpler. No need for rabies immunoglobulin, just 2 vaccine boosters and you're done. It's a true game changer. Now, for anyone working in a hospital, this is a really important point to drive home. Yes, rabies is a terrifying disease, but the risk of catching it from a patient is incredibly low. I mean, we're talking practically zero outside of something extreme like an organ transplant. So your standard infection control precautions, gloves, gown, mask, eye protection, are perfectly sufficient. And really, all of this brings us to the central paradox of the rabies virus. It's a disease that is virtually 100% fatal, but it's also nearly 100% preventable. The entire outcome, life or death, is decided by just 2 things: knowledge and speed. We hope this deep dive has been valuable for your practice. The paradox of rabies, that our tools are nearly perfect, yet the stakes are absolute, really makes you think. What can the long fight against this ancient virus teach us about the new ones just over the horizon? Let us know your thoughts in the comments. And of course, please subscribe for more deep dives on the pathogens that shape our world.